Okay, Kathy.
Well, actually, what I was going to say is, as we've been saying, excuse me, um, all of us know Janet quite well and appreciate the many important things that work that she's involved in. And I, I just would remind you all that she is now in her fourth term as a Boone County commissioner, doing important work for our county. And we're very pleased to have her again today to talk about this important issue of access and availability of mental health services in our area. Welcome, Janet.
Thank you so much. And I really do appreciate the warm welcome and when you were talking about using Muleskinners as a resource, other people having, used the catchment of information as a resource, I've used it. And it's you all have a way of having a bead on what happens in our community and the people that are making a difference. So I appreciate that. Um, Today, when Kathy reached out and said, "Gosh, would you be interested in talking?" I'm like, "Yeah, give me the opportunity to talk." How sad for you all. But this is something that about which I have a great passion, and I'm probably a lot of what I'm going to say will be things that you know. So I'm going to be preaching not just to the choir, but to the alto section of the choir, as they say, because this is information that I think a lot of you have dealt with in your personal and probably professional lives over time. Um, Something that I think most of you know is I grew up in a family of physicians, and that is important because one of the things that I believe has impacted the providing of mental health care in this country is that we do not have sufficient folks going into psychiatry and those and related fields. We have a system in medical school, in medicine generally, where people are more likely to go into orthopedics or into cardiology or those kinds of professions where people get a whole lot of money and we've never really put the resources into making sure that people who have that desire go into the specialties where that kind of form the framework or the skeleton for the provision of mental health care. So that's something that, and I really do believe there's a bias in medical schools. I think there's a bias among practitioners to that has led to that in part. And so that's something that I think sort of underpins some of what we see when we look at what's available for communities, even communities like Columbia, like Boone County, with a medical school. You see fewer people going into those specialties. So that's something that's sort of as a backdrop. The other thing that I'd like to, in terms of laying the framework out for this discussion, is think back, and I I was around back then in the early '60s for for JFK, and then President Johnson working on the Community Mental Health Act. And that's one of the things that our the committee that you were referring to before, when policing justice and mental health, when we started that committee work, we started looking back to how did we get where we are in this country. And when the Community Mental Health Act was put in place, I think everybody had really good intentions about what would happen. And part of that was to shut down some of those just awful institutions where people went through treatments that you wouldn't subject anybody to. And it was just, we were institutionalizing people. We were taking people out of society. We were subjecting them to some horrific treatments, and we weren't bringing them back into the community. And what happened, and I think folks on this call would probably concur, is we closed down a lot of those institutions, but we never did build out community mental health as we should have. And what we're living in now as a society is a space in which we are still we are still scrambling to find the services, to find the spaces in which community mental health care can be provided. And we see that especially in this Missouri Association of Counties committee that I chair, this Policing, Justice, and Mental Health committee, steering committee. We have Roger is a member of that. We have prosecutors like Roger, we have judges, we have public administrators. And public administrators are the other side of the coin when we start looking at where people end up if they have behavioral health issues. Often they, unfortunately, because of the lack of mental health services, they'll end up into being kind of floating into the criminal justice system, but they may end up on the probate side as well. And so they may end up with a public administrator, but on both sides of the street, when our committee deals with this, we look at people like Roger, we look at people like Shemin and her colleagues around the state, and the same issues are confronting both of those groups. It's like, well, where is treatment? Where is where are the beds if you need an an inpatient treatment facility? Where does that exist? If it's an outpatient facility, where is that? And is it even available for people? Or are these people that have to have insurance to get into that kind of care? So those are the kinds of questions that we see happening now. And it's gotten worse, I think, in the last several years, partially last year when the 3B or B time, B cubed came down. That was sort of the death knell for a lot of the work that's being done or has been done for building up community mental health, was the work in the federal government to really cut off funding for a lot of the programs that we look at. So that's sort of the backdrop to what's happening now. And other pieces of this that I hope this is not something that ever has impacted anybody in this call, but when we also look at that kind of backdrop, there are statutory prohibitions for providing funding for care for certain sectors of our community. And we have a thing called the Federal Medicaid Inmate Exclusion Policy, which is a barrier to funding treatment for folks who are in our county jails, also in our prisons, but in our county jails, even people who are not yet convicted of a crime. If they spend over 30 days in a county jail, they are not eligible for Medicaid services, and therefore in most jurisdictions they don't get treatment. So that's something that's happening now. And this may sound like Debbie Downer. I'm going to get to the good stuff, but this is the Debbie Downer part of this conversation. And it has the other piece that's happening is and I think Mari, you're sort of one of my experts in all of this. But when you look at how we fund healthcare in this country, and especially how we fund behavioral health care. That the vast majority of the funding from that is coming from the federal government, and it comes down to the state. And despite my complaints all the time that it should come to the counties because we actually know where the needs are and how to utilize it, and that we will use it responsibly, it comes down to the state. And so the place where that funding lands here in Missouri is Department of Mental Health, the funding that we're talking about. And one of the impacts that we've seen over time is DMH has a huge problem in getting services out to down to the local level, and we see that for instance, in Roger's shop, we see that in a situation that continues to exist. When I was here the last time, I think 2 years ago, I was talking about people who are sitting in our county jails awaiting treatment. Now that number has grown to over 500 people across the state of Missouri who are sitting in county jails, who have been found incompetent by a court, by a circuit court, and are awaiting a treatment bed with DMH. And the wait often exceeds 2 years. So over 500 people are sitting in county jail awaiting that treatment bed. And this is something that when we, Roger and I and other folks, have gone to Jeff City to talk to the budget committee, for instance, in the House and the Senate, and to talk to various senators and representatives about this issue, DMH simply says, well, we don't have the resources. We don't have the inpatient treatment beds. We don't have all of these other places. And yet all of the funds are going through DMH. And so that's one of the things that we've focused on in our committee work. We've focused on also on a national level, is to say, what is happening with those dollars? Because quite honestly, I suspect that most of the folks on this call have insurance. And if you have insurance, if there are clinicians available in a community, you can get treatment. You can get into, for instance, there's an inpatient hospital, mental health hospital on 763 here in Columbia. If you don't have insurance, if you're, for instance, a person in the treatment court process in front of Commissioner Clevenger, they won't take you because you don't have insurance. So that becomes the real problem, is the provision of services. If you have insurance, you're probably going to be okay, or relatively okay, if there's clinicians available. It's the folks that don't have the insurance, aren't eligible for Medicaid. Now with HR 1 that's coming through Congress, that has created an even bigger catastrophe for folks that have been perhaps Medicaid eligible. Now we've put more of the burden back on the states, on the people in the states, to pay for those changes, those Medicaid changes. And so it really has created a nightmare for getting people services in this area. So that's a piece of it, is how the funding is distributed. But the other piece of it, quite honestly, is DMH itself. And I'm gonna bash DMH. And I think Roger has been doing this as well, looking at the DMH budget. It's really frustrating when you look at it, but it is a hodgepodge of programs that have been requested by representatives and senators in various areas to provide a service, a bright, shiny toy, something like, for instance, a 24-hour crisis center in a community. But the problem is for most of these people is there's no continuity of care. And so when somebody is put into a place like a crisis center and is released after a 24-hour hold, there's no place for them to go. So really what we come down to for the provision of care, and when I look at how somebody in a mental health crisis, or somebody with mental health or behavioral health challenges is going to navigate our system, it's it's if you look at it as you're on a high wire and there should be a net underneath you. But if the net has holes in it, if the net isn't strong in certain places, you're going to end up if you fall, you're going to fall through and hit the ground and go splat. And that's what's happening now is we don't have that safety net across that person's lifespan to be able to get them from one place to another, to get them through that mental health crisis into the next space where they need that care. And a large part of that is due to the bottleneck that has happened with DMH. There is no continuum of care. There's not even an effort at continuum of care. There is not an effort at being transparent and accountable with the funding that comes down from the feds, even with the limited funding, the more limited funding that's coming now after the big, beautiful bill. And so now what we're seeing is people that are left out, that people that are dropping to the ground, that they're falling through that net because there's nothing to catch them. And here in Boone County, for instance, we have people sitting in our county jails, in our county jail, awaiting that treatment for over 2 years. We have people who are taken by law enforcement, somebody who is in mental health crisis, who is taken to that 24/7 or that 24-hour crisis center. And they go in one door, and if they get there when the clinician is not available, they're told to come back tomorrow. Yeah. Or they might be seen and they're only able to be held there for the 24 hours. At the end of 24 hours, they have to leave, and there's nothing to take them to the next spot. And there's no service, there's no space, no bed, no caseworker that will manage them to keep them connected so that they don't fall off and go and just cycle back through. And one of the things that's happening right now is there's 2 bills, one in the House and one in the Senate, for something called assisted outpatient treatment. And that sounds really good. It's to keep people out of jail if medication is something that can help them cope with their mental and behavioral health issues. If we can keep them on that medication, that's something to keep them out of jail. But the question becomes, if they need other services aside from that medication, do the other services exist? And that becomes the real question, is what are the other services that somebody needs? This isn't it. Think of it as if you're a quilter, excuse me, think of making that patchwork quilt. And if you're lacking pieces of the quilt, then you're not going to be able to provide the services that that person may need to continue on the path towards health, towards mental health. and I apologize, I'm sort of jumping all over the place, but this it's like a whole it's an onion with a lot of layers. The last Debbie Downer thing that I'm going to talk to you about is in the budget, in DMH budget this year, one of the cuts that's been made, again, this is a behavioral health issue, not just a mental health issue, behavioral health issue. A lot of folks utilize substances, excuse me, to kind of mitigate some of the effects of mental health challenges. And so we see a lot of folks who end up overdosing on opioids. One of the ways that all of us here, but mostly first responders, can utilize to make sure that those people stick around is a thing called Narcan. The funding for the Narcan that we've been getting to all of our first responders across the state has been slashed in the DMH budget this year. And to me, that's one of the things that, we know it works. We know it brings people back. And we might need a couple of doses to bring them back, but we need that tool in law enforcement, in all of our first responders toolkit to be able to do that. With this slash to that piece of DMH's budget, that's going to make it much more difficult for our first responders and for just individuals who would otherwise be carrying that Narcan with them, make it really impossible to do their work. So with all of the Debbie Downer stuff, there's a couple of really good things that have happened in the past few years. I think since I was here last, actually, we now have 988, which is not perfect, but 988 actually does a lot of good because it is it gives people a place to talk to someone. It can help direct people who are in behavioral health crisis to services. Here in Boone County, when we first realized that 988 was going to be a thing, we brought together all of the first responders and said, did you even know that 988 was going to happen? And they were like, no. But we brought them all together, and now we have 988 integrated into our 911 center. So we actually have a seat for the 911 in the 911 center for a 988 call taker. So that really has been helpful in terms of directing resources to people who are in behavioral health crisis. And it really shortens the time, and it makes sure that we're sending the right resources to someone in crisis. If you know that someone is in behavioral health crisis, then you're going to send one of the first responders, but you can also send a behavioral health resource at the same time. So that's been hugely helpful for what's happening here. The other couple other things that have helped a lot is, and Roger's got folks that participate in this. We still have the mental health staffing that happens through with a judge here in the 13th Judicial Circuit, and the stakeholders that have clients they're in our county jail who are identified as having a behavioral health issue. So those folks' cases are being monitored. That was one of the ways that we first saw how long people in behavioral health issues were staying in our county jail. That was sort of the canary in the coal mine for us to be able to know that so and so has been there for over a year. Those kinds of things were made aware of. We were probably one of the first counties to know that was happening, I think in part because of that mental health staffing. So that's happening here, and that's been a godsend, I think, in terms of people coming together to say, why is this person in our jail? what kind of interventions do we need to make? How do we make sure that their behavioral health issues can be met as best as possible? And having the prosecutor and the public defender and working together to find a solution has been, I think, a gift. And kudos to those offices, because it's true, when you start thinking about it, sometimes that's a challenge to have people that are on the opposite sides of the street. But these are people that are working together. The public administrator is part of that conversation as well. Excuse me. And so it's really, I think that's been a really important thing. And that started because Rusty and Antel and I were talking one day, and Rusty was like, I wonder if this kind of model has ever been used, or if it would work here. And we met with Leslie Schneider and Chris Carpenter. And Chris was the presiding judge then. And Chris said, I'm willing. And we said, Leslie, would you be the judge? And she said, yes. And so that's how that started. But Rusty Antel, said, gosh, could we do this? And that was what kicked that off. So that was pretty cool. The another thing that's happening now that really is it's sort of an answer to the problem that I think DMH and this kind of fractured look at how we provide mental health care in this country, is something that we're using a model that SAMHSA recommends, and that the National Association of Counties has recommended. And we are in the beginning phases of creating a health and justice coordinating council. And that brings together all of the major stakeholders in the community, including, and I'm so proud of these people, the hospitals are at the table. This has never happened before. This has been like, for me, this has been 14 years in the making. Somebody said, gosh, 14 years, you're just, and I said, I was a Jack Russell Terrier in a former life. So sometimes you have to just stick with something. But we have both hospitals represented on this, in this team. We have the public administrator, we have law enforcement, we have all of the agencies that need to be at the table to say, what are the resources, where are the gaps in resources in our community, who has the ability to change a process that may be holding up treatment for people. And so that's what we're doing here to try to say, for instance, we have a resource that is funded through DMH. It's called a community behavioral health liaison. In many jurisdictions, that there is local control over what that person does. We've had a problem here in not being able to control what that person does. So, if you need a behavioral health liaison, a resource, somebody who can, for instance, go out with the first responder and be part of a team that de-escalates a situation, then we'll be able to use that person in that way. The other day, we had a situation where we found out that there was, when people are sitting in our county jail, and the healthcare people in the jail don't have access to their medical records. So it's medical people in our jail don't have access to the records from, for instance, Burrell. And it takes 30 days to get the records if you're lucky. That person's in behavioral health crisis and needs to, and the healthcare folks in our jail need to know now what's going on, what their history is. So that's part of what we're doing with this Health and Justice Coordinating Council, is working through those issues and streamlining where we can, making sure that we protect people's constitutional rights, obviously, but at the same time get the care for people that helps them. I think about my niece was diagnosed with diabetes when she was 7 years old, and I think about her when I think about people that might be misconstrued as to if they're having if she were having a diabetic issue, would somebody be thinking that she was being violent, acting in a violent way, and would a first responder, would law enforcement think that she was a threat to them? And if they knew that she was diabetic and that this could easily be part of that a reaction to a situation with her blood sugar, could would that be something that they'd want to know? Of course, they'd want to know. So that's part of what we're doing here, is trying to create the net for the person that's the high wire artist, the really nice quilt that is stitched together well, that doesn't have any weak spots. But that's what we're trying to do here, because that should have been what the Community Mental Health Act in the early 60s. I think that's what President Kennedy wanted to create. That's what we all wanted, but we didn't put the resources into it. We didn't make sure that everything was stitched together. And so that's what we're trying to do here in Boone County now. And with the help of people like Roger, we're working across the state to help other counties do the same thing. Because people often, companies that have a profit model, aren't looking at creating that system of care. They're looking at selling a service. But county government is about how do we take care of people. So that's what we're doing. So with that, I've talked a lot, and I'm hopeful that we can have a conversation.
Yes, I think although we are somewhat few today, we have some very experienced, powerful voices on this topic sitting with us. So, though I've jotted down 3 or 4 questions of my own, I think I'll call on others first. Kathy has her hand up.
Janet, would you say more about the bias against mental health that you see in our um, medical education system? And have you had an opportunity to talk with like the recruitment people here about the about dealing with about getting more people into the mental health field?
Um, you know, and because everybody I'm going to talk about is dead, I could say this. I'll probably be haunted, but I just remember, even as a kid, the physicians in my family, if they were surgeons, they really didn't think that the folks that were in psychiatry, in those kinds of professions, were doing the same kind of hard work. And I think that still happens. I think there's a when you talk to physicians, there's a bias toward toward the people who are doing the surgeries. That's been there, and people don't want to talk about it, but I think it's still there. And you see it also in the dollars that they can pull down. There's a huge difference in how much money somebody can make. And when you look at people in the medical school, you have these kids that are looking at, you know, I want to do a residency in blah blah blah. Well, they're gonna, if they're going to make more as a surgery resident, than they are, and especially if they're going to go into a specialty from there, they're just going to make more money. And so, I think it's unfortunate. And I've talked to people in the medical school about it, because it's like, I we're going to have to get over that kind of bias. I mean, there's bias I think everybody would recognize that we have a bias about mental health. A good friend of mine who used to teach a lot of mental health first aid training courses around here, she said mental health is the only non-casserole disease. If you have any other disease, people think, oh, what can I do for you? But if it's a mental health challenge, it's like get over yourself. And people still don't recognize it as, it's gotten better, but there's just a bias about mental health, and people just don't want to talk about it. We're getting better as a community, but it's still there.
That seems really extraordinary, especially in the cases where the mental health issue is so obvious
Hmm.
and someone is in such extremis that they're being held in jail or something like that.
Yep.
And everyone agrees that it is a mental health issue. Um, Other times I can see that we might be able to get over ourselves, but in those obvious cases, it just
Yep.
seems extraordinary to me. Herb.
Thank you for bringing this up. It's my personal feeling, and Sue's, that situation is much less promising than it was a half century ago when the Mid-Missouri Care Center was established as a community mental health facility. And I think I discussed this with you and your mother, of course, head of
Hmm.
Department of Health, um, when they staffed it early, they hired a clinical director who was a fireball, and the university had a hand in it. I wonder whether we'd have a problem with the university. Grunberg had been director of Bridgewater State Mental Hospital, so labeled as for the criminally insane, and caused to be the filming of Ticket Follies, successor to The Pit, which was, which, I mean, it's horrible,
Hmm.
and displayed the consequences of no funding.
Yep.
He was fired for his efforts. The film was banned in Massachusetts, but Mid-Missouri's Mental Health Center hired him as clinical director.
Yep.
Is there any way to put fire under the seat of the right people as advocates within the university? Because the university is not going to fully control this, but they are an essential advocate. And I don't think they're advocating much.
Well, I think finally having, and I appreciate that so much. I think finally having them at the table for this Health and Justice Coordinating Council is has the opportunity to be transformative, because we haven't even had the opportunity to really have those conversations, to hold them accountable, to say, you're part of the solution. And there's not that, on the mental health side, there's not that institutional knowledge anymore of what it used to be, what it can be. The other piece of that is, and this is why people like Roger and I go down to Jeff City a lot, is getting the funding for it. Making sure that people in our state legislature understand how this, if they don't care about the people, they should look at the dollars. This is an area that, because we have not dedicated enough resources to it, it's sucking us dry. Every hospital that gets these folks coming in the door, if they're coming into their ER, they are the kinds of resources that they're using for these folks are just, really devastating the ER.
So you're
And
saying something like an injury uh, causes a lot of expense that might not have been needed.
right, well, and it can be that, because we haven't addressed that that it really becomes down to if we start looking at things early on, if we get people the kind of care that will, and the kind of continuum of care that folks need, then it's less likely they're going to end up in Rogers, with Rogers' eye looking at them. It's less likely that they're going to end up in our county jail. It's less likely that they're going to end up in all these other systems that we're going to be utilizing the heavy duty health care in it at MU or Boone or at the VA. It's really a question, if we don't care about the individual, then we really need to look at the dollars, because we're expending a huge amount of dollars. And quite honestly, and Mari, I think you'll appreciate this, you know, when Boone and the university came to the table finally for this Health and Justice Coordinating Council, it wasn't because I'm a Jack Russell Terrier. It's because all of a sudden the funding is the issue. They all know that because because Medicaid is not going to be there to sustain this, that they're going that the kind of reimbursements that they're getting, especially under the big beautiful bill, their reimbursement rates have dropped. And so they're looking at it and they're saying, gosh, we need to join with these people because we're going to lose our collective fiscal asses, because this is the only way this is going to work. And so it's not I'm glad that we've stuck with it long enough that now they realize they have to play with us. But now they finally realized that they have to play with us because the dollars don't work anymore. The dollars don't work for them to ignore ignore these issues. So I mean, I wish I were just really smart. I'm not really smart. I've been around long enough that now they finally they finally figured it out.
Well, Roger, your name has been invoked by several of us, so we're eager for a comment or a question from you.
Yeah, just a comment following up about asking on the emergency room visits. An example, recently I had a case where it was an unsheltered person as a victim, and we had their medical records for about 3 months, and nearly every single day the person was transported to the emergency room by ambulance. And half of the calls were just because maybe somebody stole their medication or they needed a refill on their medication. And the only way they had access to services was to call an ambulance to come pick them up. So very expensive, obviously.
Yeah. What a huge waste of resources when and here's one of my complaints. There's we have these designated mental health care providers for areas. And they've gotten a contract through DMH, and every area of the state has a certain company that works for them. One of the things that DMH has provided are these community behavioral health liaisons. Well, those individuals are assigned to those companies that are in the jurisdictions. That CBHL, as we call them, that CBHL could be utilized to be the caseworker for this person, like Roger's talking about, a person that's in the unsheltered population, to make sure that they are getting their meds, to make sure that things are happening. But it takes that coordination of care across all of these systems to make sure that happens. It's not happening now. DMH is not holding these companies' feet to the fire to say, what's happening with these individuals, and are they using these really expensive ways of getting care, whether it's a jail or an emergency room.
Right. Marie.
Thank you, Janet, for your doggedness in continuing to tackle this issue. And it sounds like you're making progress locally anyway. I have a couple of questions. One is whether the substance abuse side of things is equally fragmented, or is that any better than the mental health services side?
I think it unfortunately depends in large part about who's the designated provider in an area.
I see.
And that's the sad part, because the SUD issue is huge, and often we see it in combination with the mental health issues. But again, it really comes down to the two words that I believe are important for people like me and Roger, but should be for these organizations, are transparency and accountability. All this money is coming down again from the feds to the state, and then into it's essentially mostly going into these organizations that are assigned to provide care in our communities. And if there's not oversight, if they're not held accountable, then we're not going to get the bang for our buck that we need if we just think about the dollars. But we're also not going to get the care for these individuals that we need. And then our state legislators are going to say, well, we've got to balance the budget, and that's when we get the most ridiculous things like cutting the funding for Narcan. So it really is. I tell you what really kind of blew my mind. I was preparing to go down to testify in front of the House Budget Committee earlier this spring / winter, whatever it is, and a friend of mine in the Callaway County Public Administrator Department gave me a spreadsheet with the DMH budget. It was all the entire budget. And I looked at it, and I kept thinking, oh my gosh, it looks like all of these different wheels going, because it was built around projects. It wasn't built around how do you create continuum of care for the people you treat. And I was like, it was like a revelation. I don't know who, I was like, oh my gosh, this is what's wrong with this. And it's been created because a legislator says, I need to show my community that I've gotten something for them. So, they're going to build this really cool center in our community. But DMH is not looking at any of this as a continuum of care. And very, like, within a day of having that epiphany, I was in a meeting with Senator Crawford and with the higher ups at DMH. And I was challenging their attempt to move responsibility for a group of people that receive care from them, or supposed to receive care from them. And I was there to challenge that, to say, this doesn't work. Here's why it doesn't work. And I finally said, here's the problem. You're not creating a continuum of care. And the director of DMH slammed her hands down on the table and said, if I could start over, I would throw everything out and create a new system. And I looked at the senator and I said, that's exactly the point. And, but when you look at it, and somebody like Mari, who's been in the thick of this for a long time, you see it in terms of when you've got somebody that needs help, and it's not a one-off.
Right.
It's people.
Never is.
It never is, right? It's like, how, you may need this person. Janet may need care for an extended period of time, but we haven't built the system like that. And we've allowed this to continue. And Herb, the folks that you were talking about, the firebrand kind of people say, No, I'm not gonna be satisfied with a system that doesn't provide the care. And so I think a big piece of this is, is continuing to go to Jeff City, and, when Roger is wearing that black robe, to say, I'm not tolerating this. This isn't how this system should work.
Well, my other question has to do with exactly that, and it's about the bill that has made it through the House now and has gone to the Senate, um, that will institute work requirements for anyone to receive Medicaid.
Yeah.
Um, and in reading the bill, it does exempt people who are on Social Security disability, but we all know that that's a really difficult process for anyone to get on disability. So will the people who, I mean, I can't imagine that people with severe mental health issues can meet work requirements in order
Right.
to get coverage.
Well, and you've got people, I mean, the um we've challenged that, and and other people that are challenging that bill are folks who represent, or have as clients folks with developmental disabilities. Often folks with developmental disabilities, we're seeing more and more of folks with mental health challenges and a developmental disability. So, and there's no way on earth that these folks are going to be able to meet that work requirement. So we have, so if you want to think of healthcare as a funnel, we have so narrowed the funnel to be able to even get into the system, in terms of eligibility for funding. Because again, as we started off this conversation, if you have insurance and there's a provider, you're probably going to be okay. It's our brothers and sisters who don't have those resources and who have those challenges, and those are often generational challenges, because their impact, so much of this is not, it's not just that it comes down, it's part of your genetics. It's often, there's trauma that comes into this. There's all kinds of issues that lead somebody to being in that kind of system. But we have changed our minds. And I think, to Roger's point, one of the ways that all of us need to advocate to the state and to our federal representatives is, just look at the bottom line. And the situation that Roger described, hugely expensive, hugely expensive, and not effective, because if every day you're taking this person back to the ER, you haven't solved the person's issue, but you have wasted so many resources. And again, I think, that's why Rick Ransom and the folks at MU, are on board. That's why Brady Dubois and his folks are all on board to join us with this Health and Justice Coordinating Council, because they see it. And they know that the dollars don't work, and the resources have to be, we have to be smarter about our resources, and the resources with what's happening in DC as well. There's going to be fewer and fewer resources from them to this state. So we just have to be smarter about how we use them.
Well, it does amaze me how quickly the hour goes when we're having this discussion with Janet. We have time for maybe a couple more questions.
I just want to point out, Alice, I think, posed a question
Oh, right.
in
Yeah.
the chat.
Yeah, let's see actually there might be a couple. Let's see if I can. Yeah, Alice asks, what's going to happen when we lose federally qualified health centers? Don't they have mental health clinicians, I guess, in those federally qualified
Yeah.
health centers?
Well,
And
yeah. and then our VAX Opportunity Campus participating in the coordinating council. The goal is to have in the coordinating council both a high level group of folks who actually have the ability to push funding issues and to push policy, and then work groups. And I think the VAC Opportunity Campus folks are probably going to be part of the work group. We're right now where we are is we're creating the bylaws for this, because we have to have a mechanism for this to work and for people to be bought in and be part of the system so that they don't run for the hills. Because the other piece of this coordinating council is a data sharing platform. Because that's a huge piece of it. When I think about my niece, and I think about her diabetes, if she were having that healthcare crisis, is somebody going to think that she's acting in a manner that scares law enforcement? So we've got to have ways that are sensitive to healthcare protections, HIPAA and all that stuff, but also have appropriate sharing of data so that we make better decisions. So that's part of what's happening there. So I think that's a piece that I'm hoping that VAC would be able to participate in, especially on the data sharing piece. There's going to be certain levels of permission with that. We're looking at we're seriously considering a program that that's being used over in Johnson and Douglas County, Kansas, called My Resource Connection. And I think, Roger, was that the one that did you go out to Johnson County and Douglas County? I can't remember.
Yeah, I did a site visit there.
Yeah. And so that was we're looking at that one to see if that might be a way that we can do some data sharing here. Right now, I'm working with the jail and their healthcare, their in-house healthcare and their mental health care, and working with the hospitals to see what data points that they can share to make the work better, smarter, and try not to do what Roger described. Try not to have those kinds of constant back and forth to the ER, but be smarter about healthcare for those folks.
Well, I remember your first campaign, Janet, where you often made this remark that you just thought you weren't too sure about this move because you thought you were just like the most unpolitical kind of person with your background and interests. But apparently, working over all these county budgets all these years, over a decade now, you've seen how some of the political machinations can work, and pointing out, real stupidities and, lies, and how we're spending our money and how we're wasting our money. It just sounds like a good plan of attack to me, and I want you to let us help you with this as much as we can. I think your colleagues and fellow public servants are seeing this too.
Well, I appreciate that. A lot of this is making sure that our legislators know what we think is important. And we have some of our folks here in Boone County. We're blessed to have people like Greg Bush, having somebody with a healthcare background down there is just, he is a godsend to us. He sits on the committee that on which Roger and I sit, that health, policing, justice, and mental health. He is our legislative person for that, and he actually has attended our meetings both Zoom and in person, and he's really been very helpful in all of this. So having folks like Greg and the rest of our team, they just need to hear from us to say what we think is important. Right now, I talked to John Martin the other day, and I was like, honey, you got to fix this Narcan cut thing.
Yeah.
That's
No, that one is so obvious. I mean,
yeah,
we've had good results, right? I
yeah,
mean, the number of overdose deaths have really gone down since the
yeah.
Narcan program came through. They want to throw that away?
Yeah, that's just, I mean, and how I framed it to him was, do you want to take that tool away from law enforcement and
Yeah.
from our fire folks and our EMS folks? Do you want to take that tool out of their hands to save a life? I don't think you do. So,
Let's see, Steve, can you explain your comment there
oh yeah,
about
Brian
Brian
Nooner.
Neuner?
Yeah. Actually, I think I can. So I've actually met with Brian. I've attended the State Mental Health Commission and met with Brian about a year ago about issues with DMH, especially on the DMH holds, the over 500 people that are on DMH holds in our jails. And I talked to Brian uh, just a couple of days after the commission had met, and I said, I hope you understand, Brian, what that DMH hold that the director of DMH was telling you all about, because she said it with a laugh at the commission meeting. And I said, this is the reality of it. And this was actually a bit over a year ago when I had that conversation with him. And I said, here's the problem, Brian. I said, this is a lawsuit waiting to happen.
Yeah.
These people, this is a 1983 action that will be filed. And last November, that lawsuit was filed. So DMH is now looking that square in the face, and Brian Nooner was one of the named defendants in that lawsuit.
Yeah, this Steve, can you guys hear me?
Yeah. Hey, Steve.
So when I worked for social services for the Medicaid department, I worked quite a bit with Department of Mental Health, and even though Janet, the DMH is appropriately badmouthed in some ways. I will say that they're very fragmented, and part of what I experienced with working with them is that they have some really, really good people and initiatives out of there. They champion the issue of changing the language around, for instance, behavioral health and opioids and things similar to your conversation about persons with diabetes, that we think of opioid or substance use disorder as a disease and not a moral failing. So they've done a good job with that. They've worked really, really well with Senator Blunt when he was in, and he's been a champion of mental health. That said, the other thing about the Department of Mental Health and why I mentioned about the Mental Health Commission is that the DMH is the only department in the state that the director is not appointed by the governor. They are appointed, the director is appointed by that Mental Health Commission. Now, the Mental Health Commission members are appointed by the governor, true, and have to be approved by the Senate and things. But back in the day when, Greitens was trying to get control of the directors, and you see the impact of having different directors be appointed by the governor, they are less affected by, the state of politics when it comes to appointments than are the other folks. Now, that's it. They're still at the mercy of the budget, right? They're still at the mercy of that, but they're able to more effectively, in some ways, to advocate for departmental things. And so I think you're right. I know Val Hune, good lady, but their hands are tied. She can only do so much. And you're right. When you look at the minutes from the Mental Health Commission, you will see the different areas and how many staff they have, which represents like for programs
Yeah.
that they're over. So
Yeah.
it's a hot mess for sure. So anyway,
Well,
thank you so much for your work on this,
well,
Janet.
If I can add to your
yeah.
thoughts, Steve, I think a lot of the reason it's a mess historically is that it's been so heavily dependent on federal funding, and that has been so siloed and funneled
Yep.
to specific purposes.
Yeah.
So,
Yes.
You
Yep.
know, and to both of your points, I mean, I think, you know, the people that there's so many good people in DMH, and this week, at the beginning of this week, I was at a disaster behavioral health conference put on by DMH. They do amazing work. But a piece of this, I think, is like, to both of your points, it's fragmented. The whole system is really fragmented, and and I feel sorry for Val. I feel sorry for her executive team to try to figure that out, because there's all these political pressures saying, give this to my jurisdiction, instead of allowing them to do the work that should be done. That, along with, and I I would not want to be in her shoes, because the other piece of it is they've got these companies, and Burrell is the one in our jurisdiction. So Burrell is a for-profit institution, with a lot of ties to Jeff City, and there's just a lack of accountability with Burrell, both to Val, to the people, to the head, the folks that are running DMH, and to us. And so, when we say, when I hear law enforcement here saying, gosh, I could use that CBHL, I could use that person as, part of a co-responder model, I could use that person as whatever. We don't even, when I ask, why can't that happen? um, you know, the response I get from Burl is, well, if you want to pay for somebody to do that. And I'm like, wait a minute, my tax dollars are paying for that CBHO. So why isn't that how we use those things? So the structure is, I think, to Mari's point, the structure is part of the problem, to your point, right? It's the structure is what's making it impossible to have that transparency and accountability. Oh well, I'll get off my high horse.
Well, I do like the the positive appreciation of DMH at the end, having pointed out so many things. Oh, Kathy wanted to know CBHO. That is a kind of a
It's a community behavioral health liaison.
Yeah.
And actually, it was there was a it was designed at DMH, and it was supposed to be somebody who could come into the community and provide those services as needed. And in some communities it works pretty well, but I would say here in Boone County it's been pretty much of a disaster.
Not too bad. Well, I think you guys will fix that somehow. And I want to thank you for staying over time with us. It's been a
This has been fun.
distinguished group for a discussion. But I do think we'd better stop now. The recording will be there for me to listen to and think about some of this stuff again. It's really complicated and so important. So thank you. Thank you, Janet, as always. And call on us whenever we can be of any assistance on these things.
Well, thank you all. Thank you for all that you do. Appreciate you all. Have a great afternoon.
All right.
Thank you so much.
Okay, I need to stop the recording. Stop recording. I just did it.